I could see you.
What happened? Why are you laughing, Hannah? Did I miss something? What?
I was on the phone with Ashley, and then I went on. Up on that. I was on the phone with Ashley, and then oh my god, Mama, oh my god, no, I was on the phone with Ashley, and then I was like, oh my gosh, I see you on Zoom. And then I wasn't muted, so y'all heard me, and now I'm just a hot mess. You're up.
You're too funny. We love you, Hannah.
I love you too.
Okay, I'm just waiting for Martha. Martha's not here yet, right?
I'm here.
Oh, you're here. There you are. Okay, we're all set. Very good. Awesome.
Miss Erickson,
Yes.
Bia said that she's having some computer issues. She's going to be logging on probably in the next 10 minutes.
Okay, that's funny. I thought I saw her. I must have checked Martha. When I checked Martha, I must have got off a spot and checked Bia. That's what happened. Gotcha. Okay. Okay, so immunization debate. Really well written, good responses. Here, I am here. Good morning. I thought your responses were really well written. I think a lot of times you agreed with each other instead of maybe giving me some opposing data, right? But, you know, and maybe we could have used some other resources, you know, instead of like citing the other person's resource to support what we were saying to agree with them. So, you know, I'll be giving you some specific feedback when I grade you. But overall, you know, I thought we covered the topics really well. Hopefully you kind of gained some new perspective on the whole issues that surround immunizations, or, you know, we're able to maybe express some new ideas. I liked the idea of social media for reaching out to teens with immunizations. I think that hasn't been explored enough, right? Maybe we should write Mark Zuckerberg or something and say, hey, you know, here's another area of medicine from, you know, students at PMI have identified a lack of education for teens, for adolescents, right, regarding immunizations. Can you help us spearhead a project? Wouldn't that be fun? You know, that's well within your scope. We'll have to talk more about that. Okay. So questions so far, questions on readings. One thing I want to share with you is when that quiz that you took, on almost every question, so it gives me like, how's your class doing information back. On almost every question, you scored better as a class than all students. So isn't that good to know, right? There were two select all that apply questions that were identified as being really difficult to begin with, okay? That all students didn't do well on, right? Unfortunately, I don't think I get a lot of that before when I'm assigning. I get the difficulty level of the question. So I knew I was choosing a few that were really difficult, which is, you know, you don't want to give you all the easy ones. But what I ended up doing is, since none of you got them right, I threw out two of them. That's why your score was, you know, the number you got right out of 33 instead of 35. Okay. So, but I think it was still good information for you to be exposed to and to give you a challenging question like that in the quiz. Okay. So, you know, I try to take all things into consideration. So, you know, any other specific feedback on the quiz, you're able to go in there and review it, right? Okay. And everybody got all their posts in this morning on the immunization debate. I had it open, I reopened it until class because there were two spots I had to set the end date on, and I got one of them and I missed the other. So sorry about that. Darn time zones. And why can't we have Blackboard on our time zone? Maybe I'm not fully appreciating that, you know. And we see this in healthcare, is they know that there's an issue, but instead of, you know, fixing the system so that people don't continue to make the same mistake. They kind of put it on the nurses to do a workaround and maybe have 2 people check something so that the mistake doesn't happen. Why don't they just fix the system, right? So let's see, what else do we have going on? Next week is the exam on infant and pediatric exemplars and care. Okay, so don't forget your, the presentations that you did on the different, neonate at risk. I'll be pulling questions from that. I did post a study guide, but in terms of transparency, I got some things going on, okay? And I don't know, did I kind of tell you guys last week that if I get like an emergency, if I get like a phone call or something, I won't know who's calling me. So I might have to quick mute and answer it just to see if it's, somebody I must talk to. And, I'm going to have to kind of leave my phone on too, but they haven't, I don't get responses. So what's going to happen during class, right? But I'm just gonna maintain normalcy for all of us, okay? And I think it's really important to do that, right? For you guys to have that stable, normalcy in your life with me. And in the meantime, I can also demonstrate resiliency for you because I've had to kind of develop that throughout my career because things happen, right? Things happen. To quote Ruth Bader Ginsburg, sometimes you got to work hurt. Did you know she said that to one? Yeah. Did you hear that quote? She had a colleague that's husband was dying of cancer or something horrible like that. And they were working on something really important. And she said to her, sometimes you have to work hurt. And I think that's true in nursing. We've seen that, right? With people through this whole epidemic, with healthcare workers through this epidemic. So we shall continue on and support each other, right? And, we have that whole mission of PMI to prepare you to be professional nurses at the entry level for the 21st century. And we will continue the mission. Okay, enough said. So today we're going to cover 3 exemplars. I kind of want to wrap up immunizations too, and I do have an assignment. I'm going to end class at 11:30. And I have an assignment for you as an exit pass. That's 4 case study questions. So you'll go into your textbook, answer those questions as best you can. It's not a graded assignment. Once all the journal entries are in, I'll post the answers. Okay, so either tomorrow or sometime over the weekend or something. I'm not going to put a date on it. Okay, just get it done, and then I'll post the answers so you'll have them to review for the exam. Okay, so hold each other accountable for getting that done. It's for this week. Okay, let me go ahead and pull up our PowerPoint. Oh, but while I'm doing that, in terms of your presentations, I gave you all individual feedback, right? There was a general theme to go a little bit more in depth, right? To give me a little bit more, okay? This is week 6, people. It's not an all skate. I don't mean that in a mean way. I mean it in a motivation way, okay? The deeper you go, the harder you work, the more you're going to get out of this program, right? The more you're going to learn, the more you're going to be prepared for your life as a professional nurse, for your being able to sit down and take that NCLEX in the least amount of questions and ace the darn thing, right? So just remember that, okay? I want more. Alexa, play, I think she's being too quiet though. Alexa, volume 8. Alexa, play Rebel Yell. Alexa, play Rebel Yell. Alexa, play Rebel Yell. Here's Rebel Yell by Billy Idol on Amazon Music. Alexa, volume 8. Why isn't this one working out here? My IT guy went for a walk. Okay, Alexa, stop. Sorry about that. So much for my, you know the song. Play it after class. Oh, you're sorry, Matthew. Matthew says his go ahead and play Rebel Yell for me then, Matthew. It's a good song. I want more, more, more. You get the theme. There's Bia. Hi, Bia. Thank you for helping me out this morning. I'm getting a slow start, and I can just say I was waiting for you, right? We didn't want to start without Bia now, did we? Okay, can everybody see this okay? Am I missing a chat up there? I saw something blinking, but it went away. Okay, let's see. Chat. Okay. Oh, it is playing. I can't hear it though. Did you unmute?
I turned it off already.
Okay. Okay. Well, how about when we come back from break or something, you can jam it for us. It is. It's a great song, you know. Brings me back to a time when, you know, you could just freestyle on the dance floor. Okay. So hopefully you're kind of getting appreciation for what's so special about pediatrics, right? And I'll tell you, I couldn't be appreciating more kind of the difference between the focus in peds and kind of the adult world, right? And how family-centered care is so important in pediatrics and such a focus, right? We pay attention to somebody's learning style, their developmental needs, what words they use, you know, that individualization of care, and kind of working in those health beliefs of the family, and knowing that maybe we're seeing that person in this acute phase, in this acute care setting, but that they're going to return back to that family and community structure, and really having to identify what are their strengths and what are their resources, and what are the barriers and what are their needs, right? And advocating for them as a vulnerable population. You know, every child is vulnerable because they can't make their own decisions. They can't really care for their own needs. They rely on, you know, the family or whoever, you know, if it's a foster family or if it's extended family, or, you know, or if it's also school resources in the community, right? They're very reliant on others for their needs because of their developmental level and their ability to communicate. You know, there's all kinds of things that, issues like that, you know, in looking at the immunizations, you guys pointed out how in terms of accessing care in pediatricians, why should the child be held at fault? It's not the child's fault that they're not getting their immunizations, right? So, and then, you know, so what I really loved about peds, and I can appreciate this with seeing you guys in ortho, right? You know, I go up to ortho and it's all ortho. And I think, wow, you know, wouldn't I get like a little tired of ortho day in and day out for the rest of my life? You know, I can't imagine like doing 35 years of ortho, but 35 years of pediatrics, you know, when you're looking at the different growth and development, the you know, the different issues with families, and the goal, you know, of atraumatic care, and the collaboration that's needed in terms of, you know, I think for one thing, like, you know, Romance kind of had this experience in the GI lab where there was a physician that was kind of really dictatorial and wasn't really a team player, right? As much as when you go to pediatrics, that just doesn't, it feels like, you know, if somebody's going to be the kind of person that wants to work with children, They're going to be the kind of person that's going to collaborate with others and maybe just be a little bit nicer, hopefully, but so, then not only do you have all those aspects, but you see everything in peds. It's not just ortho, it's not just neuro, it's not just infectious disease or med surg or surgical or, cardiac or, you see it all, right? And you see it across the lifespan in terms of from the time even before. So if they're in the nursery and they're not really meeting nursery criteria, maybe it's a Billy baby or it's infant that's going to be going through withdrawal for a while and they're kind of full in the nursery, they'll move them to pediatrics. So we see, we'll see those preemie, small for gestational age, small size, low birth weight babies on pediatrics. And of course, when they leave NICU and they go home, Thomas, be quiet. So my dog is barking, sorry. I'm having a morning, aren't I? So I love that Tom went away for a walk and yeah, anyway, it's like, bring the dog with you, guy. So, okay, so we see everything. And from the time that they're, they go home from the nursery, they're considered exposed and they can't go back to that controlled environment of the nursery, usually. There's always an exception to the rule. And then there was a question in one of your articles in your concept. I don't know if you guys ever get the time to actually go into your concept library and look at the exemplars in there and read, just kind of review some of the articles, the journals in there to see if there's anything worthwhile. But there was an article in there that I thought was really interesting that talked about how as like somebody with cystic fibrosis gets older, should they transition to adult doctors or should they be allowed to stay with their pediatric doctors who have known them all their lives, even though now they're maybe 30 years old or, because it really is more of a pediatric disease that those doctors are, experts in. Of course, there's adult doctors, pulmonologists that are experts in cystic fibrosis because people are living longer now, right? I knew a woman who was like 60, because people can have mild forms of cystic fibrosis too. Not everybody has really severe lung damage in cystic fibrosis. So we'll see, adults still in pediatrics, especially if they have developmental delays, if they have cerebral palsy or, other developmental delays, we'll still see them. And especially if they're still being seen by, their pediatric doctors or an adolescent medicine or something. So, of course, I think pediatrics is very special, and very challenging in many ways. Kids change quickly. They really keep you on your toes in terms of assessment. They're more at risk for fluid imbalances. They're more at risk for airway, clearance issues, of course. And being vulnerable puts them at risk for a lot of other things also. So today though, and I've kind of assigned chapters that I kind of want you to, just because you never know what they're going to throw at you in NCLEX or what you're going to need to know fifth semester. It's always going to be good to just kind of peruse through the chapters and look at these different exemplars. Everything, like I said in there, from asthma right to Zika. And, and we're not hearing too much about Zika right now, are we? But remember when the mosquitoes, right? And we did see a population in Florida. We saw a little surge of Zika there where, these babies were being born with microcephaly. Do you remember that? I'm surprised they're not bringing that, they're bringing up this whole swine flu thing and, they're kind of skirting Ebola and Zika. But anyway, we're going to focus on otitis media, cystic fibrosis, and seizures, okay? Because I'm kind of following corporate's outline. So if you go back to that outline, those immunization, cystic fibrosis, and otitis media is on there, but we're doing also the simulation. Now, when is your next sim in lab? Do you know what week that is? And what is the next sim in lab? So you got the seizure sim, right? Is at some point. So I don't know if you have another sim before going, if you're going to go back and do the seizure sim or what. But that's why I have seizures in here as one of your exemplars, because you're going to have a sim on that. So kind of, I kind of talked about some of the anatomy and physiology of pediatrics, right? That's different. So, in terms of spina bifida, in terms of other, when we think of how the baby develops in utero, right? And, how early that, if they're exposed to tetragens, the woman doesn't even know she's pregnant yet. She's still drinking alcohol. And then the baby's born with fetal alcohol syndrome, right? If they're not getting prenatal care and they're not getting, of course, we know all about, needing to take folic acid to prevent neural tube defects. And, when the baby is born, of course, the cranium is not fused. So that can put, the baby at risk, increased risk for fractures. Prematurity, then the baby is, the vessels of the brain are very fragile, and there's an increased risk for intraventricular hemorrhage in the brain. So, there's special considerations with neurodevelopment. Fortunately, they do have that open fontanelle, which then if they do develop meningitis or do have a head injury, at least the intracranial pressure, it does have, they have a release valve. And we have a way of assessing then those fontanelles too, and seeing if there's an increase in the intracranial pressure. So head circumference is going to be really important to be tracking, right? Looking at the growth chart and what is the weight to the baby, what's the height of the baby, what's the head circumference, how is everything growing proportionately. So, and then looking at the nervous system, we know that those reflexes, which ones are normal at birth, the sucking, the startle, the Babinski, the little archer reflex, and these different, the startle reflex. If you, it's like you drop a baby and they're going to be like, hey, what you doing to me? So, and they're, going to bring in. So knowing that, knowing that the development's not complete, myelination is not complete. And then also, in terms of the nervous system, the respiratory center of the brain, right? So if you have an immature nervous system, then that puts babies more at risk for having periods of apnea, for having that affecting their breathing pattern. And in terms of, development, we know that it isn't great. Our assessment's head to toe. Development is also head to toe. And, from more gross motor than more out. So up, down, in, out, right? From more of gross motor to fine motor, developing as things continue to the physical development of infants as they go in that first year and onward. They become, that's how they go from crawling to walking, right? The head is much larger than the rest of the body, which makes them basically top heavy, which also puts them at an increased risk for falls. So when we're assessing in terms of their neurostatus and looking at, seizures, what are some things that you're going to want to look for? Okay. So if they have increased intracranial pressure, we're going to look at blood pressure first of all. So you have an order for neurosigns. You're going to be getting head circumference. You're going to be getting blood pressure. What do you think is a significant blood pressure finding if you're considering, that maybe they have, a head injury that's going to cause seizures? Maybe they have, meningitis or something like that could then lead to seizures, or hydrocephalus related to a neural tube defect or something else then that's going to lead to seizures. So just so you know, and in terms of teaching parents also, febrile seizures, that's more of I don't want to say it's a normal physiological process, but it's normal for the brain to have irritability when the temperature goes up and down with temperature variables. Okay, it's not so much that they have an infection that's causing them to seize, right? It's that the cells of the brain don't like it when the body's temperature goes up and down rapidly. And so kids will have febrile seizures that aren't associated with, physiological, physiology or long-term brain damage or anything like that. I think parents are very scared of, children having fevers. So that teaching about how fever can be the body's immune system responding to the infection, and it can actually decrease the length of illness if allowed to occur, at low levels like 100.5 or under 101 or even under 101.5 now. We've seen that change. What we're looking for though is, providing for comfort for the child, right? If they're uncomfortable and they're having pain and they're tachypnic and they're tachycardic and it's affecting their overall, assessment, their perfusion is not as good, they're not drinking as well and they're getting dehydrated because of the fever, we're going to treat the fever. But if they're tolerating, they're asleep and they're 101, let that process. That's a natural physiological immune system response. Okay. And we're learning more about the therapeutic benefit of fever. Okay. And I think it's really important, seizures. Okay. Seizures are scary. They're scary for the parent. I think they're still scary for healthcare workers, right? Because we're always concerned about airway, and you see somebody, suddenly maybe fall and seize, and it warrants immediate attention. So they can, it's you can reassure somebody this is a normal physiological kind of response to, it can be very common for children to have febrile seizures, and it's different from epilepsy. It's different from a pathological condition that's causing seizures. But you don't want to give them false reassurance either, because anytime a child seizes, it warrants your immediate attention, right? So, but what we're going to assess for, nausea and vomiting, indicates change in increased intracranial pressure, blood pressure, just their overall level of consciousness, changes in gait. If a child has a brain tumor or something that's affecting their intracranial pressure, are they having recent falls? Are they tiptoeing? Are they doing, having balance issues? Visual disturbances, right? Start seeing double or blurred vision. Complaints of headache, of course, is, a sign of increased intracranial pressure. Recent trauma specifically to the head. Changes in their consciousness or cognition. Poor feeding. If they're kind of lethargic, or increased irritability, first they're going to be probably more, well, it depends, because, kids with like concussions and stuff, you probably know the story of, how, you get that concussion where the brain is pushed forward and pushed back, and now there's swelling there. And then the child, you got to wake them up every hour to make sure they're okay. Versus then the baby with, increased intracranial pressure, who's like got this there's this horrible high-pitched irritable cry that's like this really telltale sign of increased intracranial pressure, or arching if they start to arch back. Arching back can be a sign of increased intracranial pressure in a nerve disorder, or it can also be the baby protecting their airway from reflux. So you'll see that a lot in pediatrics, where they're ruling out gastroesophageal reflux disease versus seizures, because sometimes when they do that, it looks very seizure-like. Do your EEG and see that the brain waves are normal. I think when we're looking at seizures and neuroassessment in general, we have to remember that there's two organs in the body that are electric. Our heart, right? It's electric. Boop, 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 right? Right? Remember starts at the SA node because it's electric, right? Same thing with the brain. You've got the neurotransmitters, you've got the electrolytes, the sodium and potassium also moving, creating that action potential, and then the brain spikes too. And that electrical activity is what you're seeing on your EEG also. Fever, pain, altered muscle, they'll have usually hyper reflexes, and have the increased tone and spasticity with increased ICP, intracranial pressure, and neuro changes. Delays in growth and development, that's more if, it's more chronic. And, of course, you'd want to assess for ingestion in any inhalation of neurotoxic substances or chemicals that have affected their neurological development and cause seizures. There's many drugs and things out there that are associated with seizure activity. Or I could take it the other way too. You have a child that's presenting that has a history of seizures. You want to really make sure that you do a good medication reconciliation, and when do they take their meds, and what are their drug levels, and have there been any lapses in doses, and here's what you also want to ask that's really important. I probably have it in here somewhere, but you want to ask the parents, when was the child's last seizure and what type of seizures do they have? Okay, make sure you're documenting that, and how often do they have seizures, so that you can really anticipate, the chance of that patient having a seizure. And you'll know if it's kind of their typical presentation of their seizure. Good Girl Scouts and Boy Scouts, be prepared. Okay, so in here that segues right into what I'm saying on this slide. Health history specific to seizure episodes. When did the event occur? Sleeping, eating, playing, right? Is there any kind of prodromal kind of symptoms or auras that the child has, or description of their behavior? Do they start to stare off? And then progression. How long do the seizures last? Have they ever turned blue or colored or bit their lip, had bleeding, apnea associated with seizures? We're always going to have all the emergency equipment at the bedside, okay? Seizure precautions, pads if necessary. We usually will put side rail pads on just so they don't injure themselves, but there are certain situations where you wouldn't want a seizure pad on the bed. If it's a crib or something and you really can't visualize the infant and they're having absent seizures or a different kind of seizure where it's not tonic-clonic in an infant and they're not going to injure themselves, then why, alter your ability to observe the child is easy. So you want to know, how long did that post-ictal phase last? Have the episodes been recurrent? Are they getting more frequent? Precipitating factors, fever, fall, activity, anxiety. Some kids breath hold, and that's kind of a normal thing too. They, isn't it funny, some of the behaviors, that kids have? And then, is it when they're playing their video games? Are there things that are triggering that seizure activity? Loud noise. I was at a speech and hearing impaired clinic as a new grad. I hadn't even passed boards yet. Here I was a new grad nurse taking care of all these kids at a speech and hearing impaired clinic. There were a lot of kids with cerebral palsy and seizures. And there was this one young adult who, his name was Robert, and he had to sleep with a helmet because when he first woke up in the morning, he would have this huge tonic-clonic seizure. Nothing could control it. He was on all kinds of seizure meds. It's so funny because this is, 1985 at Central Michigan University in Mount Pleasant, Michigan. I'm this new grad, and I've got like hundreds of kids, and I've got all these controlled substances in a file cabinet locked up. And I had my own little like spreadsheet. We didn't have computers back then. So, I had my way of like putting one line when I took the pill, another line when I double checked it, another line. I had like little asterisks that I'd write in these little boxes of my own system. It was me and one other new grad, and she got a boyfriend there at the camp. And I ended up covering like most of the thing. It was funny when I think about it. They gave us off time to go take boards. And then I went and finished. I got $1,400 in my pocket to move out here to Arizona. But every morning I'd set my alarm. So I would wake up and I'd run down to Robert's room and I'd stand there so that when he woke up and had a seizure, I could witness it, make sure he didn't hurt himself and had his helmet on, that whole thing. It was very self-limiting. It was his baseline. But here I was, what was I, 20 years old, seriously, so isn't that funny? But anyway, so you can have that kind of history of seizures. Is there family history of seizures? Complications in birth, maybe that led to this development, because there's all different kinds of seizure activity. There's infantile spasms, which is usually kind of a bad diagnosis, and changes in their developmental status, milestones, toxin exposure, trauma, fever, right? Okay, so all those kind of things need to go into your assessment. And then the physical. So you get the history, you get your physical assessment, your neural assessment. Might be cranial nerve, right? Is tongue midline, grip strong and equal, sense of smell changes, right? All those kinds of assessments. And of course, 3 and under, always a head circumference. 18 months and under, or 2 and under, checking fontanelles. Are they closed? Are they Sunken fontanelles are an indication of what? Letty? Sunken fontanelles on an infant. I'm worried there.
You're worried that they're dehydrated?
Exactly. Yep, very good. Yep. Bulging fontanelle, we're concerned about, trauma. It could be overhydration. It could be infection, okay? Or hydrocephalus, block, if the ventricles are not draining cerebrospinal fluid. Look at their vital signs. Look for blood pressure changes. Increased blood pressure, increased ICP, narrowing pulse pressure between the systolic and diastolic, increased ICP, especially followed by vomiting, sunsetting of eyes. If there's a change in the eyes, if the eyes are kind of going back, if the whites to the pupil size is changing and kind of sunsetting, that's a severe neurological finding. Make sure, so like we would have situations where kids were, there was ruling, they were ruling out child abuse, head trauma, that kind of thing. The ophthalmologist comes in and looks for retinal hemorrhages to see if the baby's been shook. Not that I would ever do this, okay? But wouldn't it be kind of funny just to keep nurses on their toes, right? Because the ophthalmologist calls before coming and assessing, and they'll say, sometimes they'll do this little slang thing where they'll say, drop the patient. And what they mean is put the eye drops in. So you do like these, the pupil dilating eye drops. And so, it's kind of a horrible idea would be to put those drops in one eye and then call your colleague in and say, something doesn't seem right about this baby, and see if they go ahead and check the pupils and see that, and they'll think one's blown, You would never do that, would you? And then you're like, oh yeah, I forgot. I got to do eye drops in the other eye too, right? Little nursing humor there. Sorry, bad nursing humor. Okay. Anyway, so cranial nerve function I talked about, and I think you'd cover that. That should be in your lab too, where you go through all of the cranial nerves. Motor function, reflexes, sensory function, right? We talked about vision or changes in smell, that kind of thing. So looking for those signs of increased intracranial pressure that could be associated with seizures. Here's your Glasgow coma scale in terms of, do their eyes open spontaneously? Are they obeying commands? And this can be age appropriate too, right? Are they looking for mom? Are they alert? Are they awake? Do they respond to sounds? And, is there orientation there? Are they speaking at their baseline? And then looking for those changes. And this is in your textbook and your reading also. Okay, so we got our early signs and our late signs. Early signs, headache, vomiting, blurred vision, dizziness. I remember this little boy, Whitney. He was 5 years old. He was at school, like preschool, and some older classmate, they were on stairs, and some older classmate jumped him kind of from behind, knocked him down, and he had a concussion. And I was like a new grad at TMC on night shift, and maybe I was still even in orientation, and he was out on pediatrics, out on the floor on Q1 hour neuros, okay? Now, if I would have been a more experienced nurse right there, I would have said, wait a minute, anything more than Q2 hours should be in ICU, right? But I didn't know better. He seemed like he was doing fine. So, I was waking him up every night, every hour throughout the night. And at 6 a.m., he was telling me jokes. But, and then like right at 6, he vomited. And then I think his blood pressure started to go up. And then he blew a pupil. He actually blew the pupil right at change of shift. We were getting him to MRI. He did have a subdural, he had an epidural hematoma. He was intracranial bleeding. They had to immediately take him to the OR right at like 8 a.m. And he ended up being fine. And they repaired it. And, this is way back. So it was Dr. Arthur Goldberg that was the neurosurgeon at that time. But I just remember that here I was checking this kid all night on the hour. And then when do those changes happen? Right at change of shift. new nurses coming out, we're giving a report, and all this stuff is, like suddenly happening, getting the residents in there. And the parents were right at the bedside. They were like, wow, just at 6 a.m. we thought he was who's that comedian, Benny Youngman or Henny, Resident Benny Youngman or something like that, an old comedian. They were referring to him and stuff. And then they said, and now all of a sudden so, they can have this slow bleed, and then all of a sudden that artery can kind of go. So, so early signs and then late signs, okay? The changes in breathing. Okay, decerabit bringing in is better than decorticate, okay? So when you start losing that, decorticate is in, decerabit is out. Okay. Fixed and dilated pupils, no pupil response, bradycardia. Of course, these are, late signs, and it's gonna lead to probably brain herniation and death if you don't immediately respond. Of course, in the ICU, they can place intracranial pressure monitoring. They actually do a drill through the skull and put in pressure monitoring. ICP should be, I believe it's like 5 to 10, but you guys don't, that's more, that's coming 5th semester, okay? But just so you know, they can do like hyper tonic fluids, right? Like mannitol and things that absorb fluid that will, if you're absorbing fluid, then you're going to be decreasing intracranial pressure. So they have those kind of ways to try to save the brain. And of course, hypothermic, to decrease the metabolism of that brain tissue. So, with head injuries and increased intracranial pressure, that kind of thing, they do have those higher ICU, techniques to try to preserve brain. And, they can even remove part of the skull in adults and things. So, so here's a typical baby with hydrocephalus and how that, how that baby would look, okay? So this baby obviously needs a shunt, right? Like I said, it's good that they kind of have that compensatory mechanism in their anatomy, right? With those open fontanelles, it kind of allows for things to kind of bulge, and at least they don't have this enclosed environment within a cranial pressure where they would herniate down the main stem and down the brain stem and go apneic and stuff. So, and then to the right there, it shows how that shunt can be placed in the ventricles of the brain so that there's a valve on there, a pressure controlled valve, that so all the fluid doesn't go running out, right? It senses the pressure and allows a certain amount of cerebrospinal fluid to drain out. As you could probably tell looking at this, as the infant grows, what happens? That's gonna, that's tubing is gonna become shorter, and they will need shunt revisions to lengthen that shunt. And it's very common for shunts to get infected. So teaching the parents, what to watch out for shunt infection, which is very similar to the signs of increased intracranial pressure, fever, vomiting. So anytime their child starts having fever and vomiting, they're going to be worried that it's the shunt. And you can imagine kids end up having different stomach flus and things where they're going to have fever and vomiting. For this child, pretty much every time they're going to have to come in and rule out shunt infection, at least be seen by their physician. So, assessing fontanelles, assessing head circumference, assessing the neurological status of the baby, getting that CT or that MRI. We don't like CTs as much because they are more radiation. Other labs and diagnostics, see how that just kind of segued into that, huh? Serum glucose, of course, right? Hypoglycemia can also be causing seizures. Getting electrolytes and calcium, because also abnormal, any abnormalities there can be associated with seizures. Getting that lumbar puncture. Okay, so what's lumbar puncture gonna, what are we looking for there? What does normal cerebrospinal fluid look like? Jackie, what does normal cerebrospinal fluid look like?
Isn't it like a yellowish, like a clear?
More clear, yeah. It might have a slight with the protein in it, might be a little, but it should really be pretty clear. So if it is more yellow, sometimes broken down red blood cells can make it turn a little yellow too, or protein in there can be, and that can be signs of infection. Certainly if it's, if it's cloudy or anything, then we're thinking meningitis.
Okay.
Yeah. And what they'll do with kids too, the older kids, if they do have a closed fontanelle, there's a manometer on there. There's a glass tube that they can hook up to the lumbar puncture, to the spinal needle, that will give them an opening pressure. They turn a valve and that fluid fills up, and wherever that goes, that will be the opening pressure. So that will determine, how high the intracranial how high the ICP is. And then what they can do with the stopcock, once that fluid comes up, then they can slowly fill each of their collection tubes with that. Those older kids that have the closed fontanelle, their fontanelles closed and everything, I know sometimes they say you don't need to keep them that flat because they'll get spinal headaches, but I think that's still a real thing. And usually they will order them flat for a while, for hours after having a spinal tap, so that they don't get headaches. Babies, we don't usually do opening pressure, because they have an open fontanelle. But getting that lumbar puncture, of course, anytime an infant comes in and they have a fever, they're underage, 3 months, they don't have a well-developed immune system, we're worried about sepsis. We're worried about, and, when we talk about otitis media, what's close to the ears, the mastoid. So for a lot of kids, they can get infections there, or, the ventricles and, other, the brains, so they can, the meninges, so they can get, ear infections, and then they can get meningitis. So, it's not as common, but any kid that comes in with an infection that's under 3 months of age, we usually will do a full septic workup, because they can't tell you, I don't have bacterial meningitis. You look at them, they got a fever, you don't know what it is. You got to work them up. So, that can be a stressful time for parents in that first 24 hours to come in and have their newborn have a septic workup, where they're having the lumbar puncture and the blood cultures and the urine, catheterization, and getting an IV start and getting IV antibiotics started, and the baby doesn't look good, usually. And then you fluid resuscitate and you give antibiotics, and in 24 hours, they look like $1 million, back to normal. And the parent's like, oh, can we go home now? And you're like, we got to wait 3 days for all the culture results to come back, because we don't know if we were treating this bacterial infection that now you need to be here for 7 to 10 days. So we're glad everything's good. And I know he looks completely healed, but we need to know course of treatment, right? So they got to hang out for a little while. Unless we, once we have an organism, like if the RSV culture comes back positive or something, then doctor's decision if they feel comfortable stopping antibiotics, or, So does that all make sense? You following me? Picking up what I'm putting down? Okay, fluoroscopy. They might do a cerebral angiography, look at the vessels in the brain, head CT or ultrasound, EEGs, of course, to look for any seizure activity, your MRI, or more contrast kind of studies where you can ICP monitoring. I was talking about that being more of in the ICU with the bolt and the pressure monitoring. We have EMU. We call them our EMU rooms, because, ostrich they're not as cool as emus. Epilepsy monitoring unit, where there's a camera up there, and in neurophysiology, they've got the recordings of all the EEGs and looking at the child's activity during any alterations, any seizure activity. Okay, so just remembering kind of that patho of epilepsy and febrile seizures and neonatal seizures, okay? Whether it's true epilepsy, and looking at the conditions then for epilepsy, versus febrile seizures, versus neonatal seizures that may be due to, we talked about the perinatal asphyxia, right? Having that, that hypoxia that happens during birth that causes damage to the brain, right? So, if they have that hypoxic ischemic encephalopathy from birth, or a metabolic issue or something. So, is the criteria epilepsy, or is it febrile seizures, or is it neonatal seizures from a birth event? 3 categories of epilepsy. So focal is one side of the brain. And they would need to look at the EEG to diagnose this. Generalized seizures involve the entire brain, or it can, and then under that category of generalized seizures, you have absent seizures, where basically sometimes it's really hard to tell they're having seizures. they look like they're staring off for these brief episodes. And then when you look at the EEG, they're actually having this seizure activity. Tonic-clonic, where they're moving, myoclonic and atonic seizure activity, where they might just be moving a certain way, one side or something, or not having any movement. And then there's other categories of these unknown kind of epileptic spasms. They might just have a little jerk or something. And then they look on the EEG, and that's actually, maybe you thought it was a tic or something, but it's actually a seizure activity. So sometimes it can be very difficult to identify that that's seizure. So I'm glad I'm not a neurologist, because I'll tell you, we have got some neurologists in this town that are so smart, really genius neurologists out there. We're lucky that here in Tucson, especially in terms of pediatric neurology, we've got some great ones. So there's also other, and this is kind of where you can almost, go into the behavioral and psych kind of areas too. There's heart syncopal events where people can have that. They might even call them like a drop seizure, but it could be like QT prolongation, or, that's causing them to have syncope. Some kids have this behavior where they get mad or something, they breath hold, and that's not a seizure. Jitteriness with hypoglycemia, it can lead to seizures, or just other jitteriness from albuterol treatments and stuff. Not a seizure. Apnea, not a seizure. Gastroesophageal reflux, I talked about how they can look really archy and stuff. Not a seizure. Cardiac conduction abnormalities, migraines, tics, night terrors, benign sleep movements. Conversion reaction can be really difficult, because kids can, and they're not faking a seizure. If they have conversion reaction, something traumatic has happened in their life, and they can't express that. And the only way they can communicate that something is really wrong is by it's like that emotional reaction is having this physical response. We have to remember how much our emotion and, how holistic we really are, right? How much does our physical status affect our emotional and, and other aspects of our human being? And how much does that emotional then come out in physical? And especially in pediatrics, kids who are having problems in school, their stomachs hurt. Well, their stomach really hurts, but nothing's wrong with the stomach, but something's still wrong. Something is still wrong. And so you just have to really, this is, in pediatrics, holism is really key. And conversion reaction is absolutely, an exemplar of that. So, that complete physical and neurological exam, right? So anybody with seizure, mental status, language, learning, behavior, motor abilities, details of any observed activity, okay? And it's really important for us to do this in the hospital and to teach the parents to do it too. Child has a seizure, put on the emergency button, right? Time it right from the beginning. We need to know the time. When did it start? How did it start? Where did it start? Specifics of the seizure. Then identifying, is their oxygenation status okay? And I'll be talking more about the safety aspects of it, okay? But really providing, that time and the details of the seizure activity and documenting it. So nursing diagnoses that then, are supported by these findings, right? So decreased intracranial adaptive capacity, risk for ineffective tissue perfusion to the brain, risk for injury because of their, especially with myoclonic or tonic-clonic seizures, risk for complications of neurological and sensory dysfunction. It's rare, unless they go into status, unless the seizure does not resolve. And, usually seizures are very self-limiting. They have this violent, really hard seizure, and then they go into that postictal phase, and they don't have any long-term damage to the brain. I think a lot of times people are afraid of that, but that's pretty rare. That's if another pathological condition is going on, or for some reason they go into status and they're seizing and phenobarb and depakine and valproic acid. Valproic acid is depakine, but there's another one that we give that's really common. We give these seizure meds, and then if it doesn't stop, then they could even have to put them in like a phenobarb coma or something to try to stop that seizure activity. There is that risk for infection, especially if they have a shunt or something like that, and pain. impaired physical mobility related to the neuro deficits that then are leading to musculoskeletal deficits, and if it's contractures or what, or, you know, movement disorders. Risk for delayed development, imbalanced nutrition, risk for fluid volume deficit, knowledge deficits. You know, it's really, I think for parents, some of these safety aspects, you know, need to be taught. Giving rectal Valium needs to be taught, so that if a seizure lasts longer than 5 minutes, they have this emergency medication that they can, you know, gel that they just, it comes in a little plastic syringe and they can just squirt it in the child's bottom and they hold their butt cheeks. And you're going to learn about that, I believe, in lab for your next sim. And they're taught to do that to then stop the seizure, or, you know, knowledge deficits related to the importance of making sure they're consistent with medication, and that there needs to be these drug levels of these anti-epileptics. And I think it's difficult for parents because, like, working at the children's clinics where we saw a lot of kids with seizure disorders, parents would call all the time, and they were filling pill boxes or something. They didn't, or they were just taking out, you know, one parent gives the medicine, another parent gives the medicine or whatever, and all of a sudden they realize they're low on their medication. And by the time they can get a hold of the doctor and get it called to pharmacy, and then pharmacies, like, maybe they have multiple insurances, so they're, you know, there's issues, and then they're running low on medicine. It's a panic, you know. And there was always so many parents in that situation where that's always, you know, especially if they're on multiple medications, to stay on top of having, you know, their medication, and then what to do. Some of these medications can be super expensive, and what if they spill them and then they can't get it prior authorized again to get refilled or something like that. So now they've actually, you know, necessity is the mother of invention. They've come with special caps on them that they can stick the syringe in and draw up the medication, so they're not pouring and spilling and running out of meds and that kind of thing. So, you know, knowledge deficit issues, interrupted family processes, right? You know, it's very difficult a lot of times, if depending on the status of the child, for parents to work. Somebody needs to be home. They're up at night checking on the child frequently. You know, it's really hard to deal with that fear of having your child seizing during the night and not detecting it. And, you know, it's kind of a reality that it could happen. It's, you know, very rare that kids will seize and the parent either doesn't hear something and wake up, or that the child has, you know, a bad outcome from having the seizure, you know. And then, you know, the self-care deficits of the child too, related to their developmental level. And then you would specify those findings. So these are all, you know, potential nursing diagnoses, and they're kind of listed in, you know, the higher priority to the lower priority right here also. And then, you know, our interventions, right, that would align with those different diagnoses in terms of injury, in terms of, you know, risk for hypoxia and damage to the brain, and, you know, things that you would teach the parent, right? So you can kind of review those in terms of, you know, padding the side rails and timing the seizures and putting the child on their side, and, you know, maintaining the airway of the child, not putting anything in the child's mouth. You know, back in the day, they'd put a tongue blade. You don't do that anymore. And definitely don't any of you, everybody listen up. You don't put your fingers in the mouth of a seizing person, right? Good way to lose a finger and to block their airway with your finger. You know, so making sure you're supervising them during bathing. I think that was like an NCLEX question or something I saw once, that, you know, it gave you like safety. I think that might've been on Kaplan. You know, what would be a safety recommendation? Never to allow the child to bathe alone, because if they had a seizure, then they could, you know, have a submersion injury, or other, you know, other hazardous activities, riding a bike and that kind of thing. You know, use of that protective helmet, like that young adult Robert I was telling you about, medical alert braces, right? Okay. The nursing diagnosis, decreasing that intracranial adaptive capacity related to reported head trauma, as evidenced by bulging fontanelle, having 3 tonic-clonic seizures in the last 24 hours, pediatric Glasgow Coma scale of 6, projectile emesis, CT indicating concussion, right? This could have been my boy Whitney, right? This was, you know, just another example of that it's a newer nursing, a new NANDA that's out there that I wanted to share. And nursing interventions for keeping intracranial pressure down, okay? Quiet environment, checking those more specific neuro findings every 2 hours. You don't want, think in terms of perfusion to the brain, right? Making sure the neck is aligned is really important. And at 30 to 45 degrees, that helps promote intracranial perfusion. Administering anticonvulsants, making sure that you know how to get the key for the Ativan, right? Because a lot of times we give IV push Ativan to stop the seizures, and it might be in the refrigerator with a key to open the lockbox or something like that. I hope they don't do that anymore. I hope they have it more accessible. I'll never forget, running to the Pyxis, getting out the key, getting out the lockbox. It's like this process. Or osmotic. I talked about the hyper. So having that osmotic effect to decrease intracranial pressure with like mannitol or something like that. Analgesic medicines, right, to keep the child comfortable. Anybody who's in pain is going to have increased intracranial pressure. So managing pain is really important. Keeping that environment quiet. Educating families and visitors also of these goals, right? Don't keep waking the patient up, bothering the patient. Now's not the time, right? And of course, pressing that emergency button, having everybody respond to the seizure, making sure that we're stopping the seizure and maintaining oxygenation, suction at the bedside. So monitoring, O2, suction, side rail pads if needed, timing the seizure, and documenting exactly what the seizure activity was. The knowledge deficit, with morning assessment, performing that learning assessment of the caregivers. Do they like handouts? Do they like handouts that have diagrams and pictures? Can they watch a video on learning how to administer rectal Valium? Who needs to know that information? Where does the child go? Do they go to multiple homes for care? Is dad divorced and they actually go to a stepmom's home or something? So you got to identify, is there an aunt that, needs to know also? They need to know their medications, their side effects of the medications, what to expect in terms of sleepiness, what to expect in terms of follow-up for drug levels, if things can be crushed or chewed, all that. When administering a medication and upon discharge. So every time I'm going in that room and giving these medications, I'm going to be showing them how much phenobarb to drop, how much, how to give medication and make sure that they're swallowing it all, right? And not creating problems for the parents. If we're holding that child down and making this a traumatic experience, we're setting that parent up for failure and giving those medications once they go home, right? So, a little bit of chocolate, a little bit of phenobarb, a little bit of chocolate syrup, or whatever the child chooses, giving a sticker afterward, all those things, okay? Involving child life, right? To normalize the hospital experience, decrease the trauma, make it atraumatic, and, and make it so that when that child goes home, they're going to be taking the medication really good for their parents and being, that increases adherence. So, and then kind of setting that goal then, right? On hourly rounds, I'm reinforcing all these things, everything they need to know. By the end of shift, they're able to verbally teach back that information, okay? And then I did attach this, a link to the care plan, okay? It's in your textbook. Okay, how are we doing? You guys want to take a quick break? It's 10:05. Go ahead and take 10, and we will resume at 10:15 and move on to otitis media. I will hang for a couple minutes. Does anybody have any questions about seizures? Okay, everybody's back? Wonderful, nice to see you. Okay, so let's talk about ear infections, and specifically the acute ones, right? Because we hate the ugly ones. So, you know, ear infections are very common in children. They have small eustachian tubes. They, you know, common illness. They have immature immune systems, right? And some kids are more prone than others, and there's surgical interventions and things they can do to help, you know, kids not get chronic ear infections. So, common illness can result from bacterial or viral, or, you know, it can just be fluid in the middle ear also. There's an increased susceptibility in infants and young children because of the short length, and it's more of a horizontal positioning, which is why you have different ways of putting in eardrops for kids. Limited response to antigens and previous exposure to common pathogens can put them at increased risk for developing more ear infections. I was just kind of looking, I was noticing that, you know, I've really done there's a lot of speaker notes in here that you can go back and kind of review too. Okay, if it seems like I'm moving through any of these quickly. So there can also be eustachian tube dysfunction that puts them at, you know, increased risk. And, you know, kids, when we think about, you know, they're exposed to more organisms earlier on in life, right? Everything goes in the mouth. They're close, you know, they play with each other and everything, and daycares and that kind of thing. There's that, you know, increased risk for these reoccurrent upper respiratory infections that, you know, where they have these increased secretions and inflammation, or if they're, especially, you know, if they're taking fluids by bottle for a longer period of time, or being put to bed with a bottle or any bottle propping, then leads to, you know, as they're eating the fluid, they hold the fluid in the back of their throat kind of thing as they're eating. It increases this inflammation in the ear canals also, and leads to chronic ear infections, which can lead to, you know, over time, some hearing impairment. You know, if the fluid is always in that middle ear and it's affecting their ability to hear language clearly, it can lead to speech impairments and, different speech problems and learning problems. So it can be significant in kids if they're not hearing well, because it impacts their development overall. Also, ear infections are painful. Kids can be fussy, they can be febrile, you know, so you do want to treat the pain too. I think it's one of those areas where we forget that these things can be really painful until you get an ear infection, right? And then you realize, oh my gosh, this is really painful. You know, it's really affecting my ability to function. And then you realize, oh, these poor kids that walk around with these ear infections all the time. Or if you've ever, you know, if your child's had an ear infection, you know, they're tugging at their ear and they're crying and miserable and they're not sleeping. And you're thinking, boy, this is, you know, this poor child is really in pain. And especially then, you know, a lot of times the ear, you know, the tympanic membrane ruptures. And, you know, I think parents get really concerned that affects hearing, but that usually heals and it's usually benign. So there's a big question out there whether to treat ear infections with antibiotics, and recent studies indicate best practice is to initially not treat with antibiotics, because a lot of these are not truly bacterial infections. We don't want to overtreat, especially young kids, with antibiotics, because they can develop a tolerance to them. It can lead, you know, we've got a big problem with overtreating with antibiotics. You know, somebody's got a cold virus and they go into the doctor and they're demanding antibiotic because they think, you know, like a shot of penicillin is going to get them better. And that's leading to all these drug resistant organisms, right? And then if our antibiotics aren't working to fight infection because we've got drug resistance, then we're going to more and more, you know, stronger antibiotics with more side effects. This is how we're seeing things like C. difficile, you know, these overgrowths of these organisms then that can be more life-threatening. So, you know, especially in the pediatric population, with something that can, you know, be treated in other ways, not just initially treating with antibiotic, but looking at what kind of things are leading to these chronic ear infections that maybe can be, you know, those risk factors that can, you know, are they exposed to secondhand cigarette smoke? We'll address that before you're going to keep giving this child different antibiotics. You know, are there, comfort measures and other eardrops or things that we can do to, you know, to resolve this versus, but, there are certain also instances where it's not going to go away without the antibiotic. If it's true bacterial infection, ear infections can lead to other complications, mastoiditis or meningitis, or, so that's where the pediatrician, has to determine the treatment. Complications with chronic ear infections, you can get hearing loss. Not the acute, ear tympanic membrane ruptures, and because really, when you think about it, those pressure equalizing tubes, that's the same kind of thing. It's really giving that ability so that the membrane's not going to rupture, and that pain, it's going to give that. It's already providing that outlet, that pressure equalization. Okay, so I talk hearing loss, speech delays. If you can have scarring of that tympanic membrane, but it doesn't usually have an effect on the hearing. So chronic suppurative otitis media is chronic drainage, acute mastoiditis, intracranial infections. Okay, so there you go. Nursing assessment, fever, complaints of ear pain, fussiness, crying, tugging at ears, but also rule out, is it more of a teething issue versus ear? You can look in the ears, see if the membrane's bulging, see, rolling head from side to side, poor feeding, lethargy, sleeping at night, waking up at night, fluid draining from the ear. So age and daycare, previous infections, upper respiratory infections, alterations in their eustachian tubes. So all these things, crowded, I talked about crowding. There is increased incidence in Native Americans and other ethnicities. So breastfeeding is best, right? Has passive antibodies and can help cut down on ear infections. If there's any underlying immunocompromise, they're at more risk for ear infections. Poor nutrition, craniofacial abnormalities. There's like the small jaw, Pierre Robin. Of course, our kids with cleft palate are going to be at a very increased risk for ear infections. Presence of allergies, anything like that that's going to cause an increase in inflammation. Family history of ear infections. Okay, kids who have ear infections oftentimes have parents who have had ear infections. So our interventions, we're going to identify the diagnosis of pain, acute pain in the child with the ear infection. We're going to do pain management, educate the family, look for any signs of effusion and that their hearing is impaired. If they come in, if they've had chronic ear infections and they go to the ear, nose, and throat doctor, the ENT, and they come in for pressure equalizing tubes, doing that post-op care, we want to prevent fluid from getting in the ear. They have little wax earplugs and different things. Or, are there drops or something that medicine that the parents need teaching on for post-op care? Encourage breastfeeding. There's a xylitol syrup that can be given that can kind of dry up secretions and things that can kind of help decrease the incidence of ear infections. But that would be something, that you'd want to make sure the pediatrician approves. And, decreasing those risk factors, especially exposure to secondhand smoke and bottle propping. Okay, those would be like two of the big ones. And upper respiratory infections. Okay, so now any questions about ear infections, otitis media, BOM? You know what BOM is? Bilateral otitis media, the BOM. Okay, cystic fibrosis. Okay, you might think, when I say cystic fibrosis, you might think more respiratory, right? But then appreciate the underlying cause of why there's increased mucus. Why is the lungs affected? The lungs are affected because of pancreatic enzymes not being produced. Okay, there's a lack. So it's actually more of a metabolic issue, okay? And it is an autosomal recessive disorder. So just think, if we wanted to wipe out cystic fibrosis, and this is an unethical statement I'm about to make, okay? Because it has to do with genetic discrimination, okay? So I'll just close it. This is wrong, okay, in this thinking. But if people didn't have babies, if people who had the recessive gene of cystic fibrosis didn't have babies for a generation, then that gene wouldn't get passed along and we wouldn't have it anymore, right? So isn't that, but, you know, to just understand how it's passed along. But then in that statement, understanding that that's unethical, right? Because at what point, you know, that's, you know, would that stop? You know, nobody's got the genetic, you know, the perfect engineering, you know, you can't. So you'll learn about that more in 5th semester with HIPAA and high tech, and because HIPAA really also goes into non-genetic discrimination, you know, goes back to like World War II and everything, right? So anyway, but it is an autosomal recessive disorder. It affects 30,000 children and adults in the United States. A deletion occurring along the long arm of chromosome 7 at the cystic fibrosis transmembrane regulator. It's responsible for gene mutation. DNA testing can be used prenatally and in newborns to identify the presence of the mutation. So, you know, remembering that somebody's got one gene and the cystic fibrosis, and then they have another person who has the recessive gene, those two get married, and then they can have that 25% chance of having a baby with the disease, 50% chance of having an infant with the carrier, and 25% chance of having normal, you know, not having the cystic fibrosis gene being passed on. So, so how important is it to do that kind of genetic counseling, right? Very important. At present, all states include testing of cystic fibrosis as part of that newborn screening. So when they get their heel poked in the nursery and that gets sent off, they should get an answer as to if they have that gene for cystic fibrosis. Okay. And there's a whole scope of this disease. Some people have very mild symptoms. You know, there actually can be milder forms of cystic fibrosis. But you know, as that those pancreatic enzymes and that nutrition and everything, as that thick mucus damages the lungs over time, usually, you know, in young adulthood at some point, now we're seeing more and more lung and actually pancreatic lung transplants in people with cystic fibrosis. You know, and there's a lot of studies on the importance of, you know, exercise and everything early on with people with cystic fibrosis. And they're getting, you know, endocrinologists are getting better about making sure that, you know, parents and children understand the importance of enzymes with every meal and snack and everything, and optimizing nutrition with feeding pumps and feeding tubes at night and things to make sure that growth and development is optimized. So, you know, the problem is that then with the thick secretions from lack of pancreatic enzyme and damage to the lungs, you know, that sets up the lungs for then chronic infections and kind of some of these lesser prevalent, you know, like they're more at risk for, I'm trying to think of what organism too. I'm sure it's in your book or it might be in my notes here, but some of these, not Pseudomonas, but, you know, organisms like that are more resistant of antibiotics. So, you know, a lot of times they'll end up with a central line or a port that you're accessing because they're going to need tune-ups and antibiotics over the rest of their course of their life. They're going to come in and need pulmonary function tests and courses of antibiotics to help prevent them from having this lung damage and in having, you know, exacerbations of their cystic fibrosis. So average survival age is 30s. Complications include hemoptysis, pneumothorax, bacterial colonization, right-sided heart failure. Remember how if you have increased pulmonary hypertension, that puts increased pressure on the work of the heart on the right side, because that's the side that pumps to the respiratory system in the lungs, right? So you have increased pulmonary hypertension, you have increased work on the heart and right-sided heart failure leading to cor pulmonale. Volvulus of, you know, so you get some GI involvement, intussusception, where the bowel can telescope on itself because they have decreased motility, decreased absorption of the gut with decreased pancreatic enzymes. So if that happens, you know, circulation to that telescoped part where the bowel overlaps in that necrosis, and they can end up needing bowel resections, or they can go, you know, septic and have necrotic bowel. That's pretty rare, probably earlier in age, like 9 to 18 months is when intussusception is most prevalent. Sometimes that can be resolved just by doing a barium enema too, and that can stretch it, and it comes, you know, the telescoping resolves. But then if you're not, you know, maintaining then bowel function, it can reoccur too. And it can be with bowel infections and things like, you know, some of the gastroenteritis then can precipitate that intussusception happening, you know. So with that decreased peristalsis in the thick secretions and lack of enzymes, intestinal obstructions, rectal prolapse, gastroesophageal reflux disease, diabetes, because the pancreas can also affect insulin production and damage of beta and islet cells. Portal vein hypotension can lead also then to esophageal varices and bleeding. So you kind of get that liver involvement with the liver and the gallstones. Because of the thick secretion stuff too, it affects the vas deferens and reproductive organs, and the actual semen can be thicker and can lead to decreased fertility and damage of the sperm. So in terms of that pathophysiology, it is an exocrine gland dysfunction. Epithelial cells don't conduct chloride, and water transport is abnormal. Sweat, so that's why back in the day, you know, they'd say kiss your baby. Is it salty? You know, get them in for screening for cystic fibrosis. Now they actually do sweat tests where they take plastic, just like almost like a saran wrap looking, I think it is saran wrap, and they wrap it around and they put electrodes underneath so that the skin sweats, and then they test it and they can determine. That's how they do the sweat test. But of course, young infants don't have sweat, right? We talked about that with their ability to shiver and generate heat, and they don't also sweat as easily, so they can get overheated easily. So they usually have to wait till they're 6 months older or so before they can get an accurate sweat study. Looking at the effects on the GI system, the pancreas, the lungs, and other exocrine tissue that have thick, tenacious secretions. So this increased viscosity makes secretions difficult to clear, which leads to the sweat glands producing more sodium. Pancreas and other glands become obstructed, so pancreatic enzyme activity is lost. So they have poor weight gain, they have malodorous stools. The tracheal bronchial glands also develop thick mucus, and lungs develop mucus plugs. So that puts them then at risk for these secondary bacterial and kind of these chronic unusual types of organisms that they can be really susceptible to mycoplasma and you know, like we don't allow flowers and stuff in the ICUs and everything because they can harbor cryptosporidium, and so there's all these other, you know, like kind of unusual organisms then that normal people, normal immune systems, we're not as susceptible to. So when they're hospitalized, reverse isolation, where, you know, you should not allow somebody who's maybe coming down with something, or, you know, to be in their room. Gown, glove, mask, you know, reverse isolation, so we're not exposing somebody with cystic fibrosis to infection, and knowing that they have those fertility issues also. So talked about in the undiagnosed baby, that salty taste to the skin because of the increased tenaciousness of their secretions, blocking, you know, causing the sodium in the sweat to be increased. Meconium might look different at birth. Abdominal pain, bulky, greasy stools, poor weight gain, current cough, upper and lower respiratory infections would be signs. Most of the time there's that family history, and so they're screening at birth and they know pretty early on. But there's always, you know, sometimes generations can be missed, and all of a sudden you can have this, you know, person with cystic fibrosis that they didn't expect, and they come in and, you know, within that first year of life, usually they'll have some symptoms, and as part of that complete respiratory assessment, trying to figure out what's going on with this infant, they'll do this cystic fibrosis testing and find out that's what it is. So if it's coming out of nowhere like that, you can imagine it can be devastating to the family to find out. So looking at, of course, full respiratory assessment, right? Work of breathing, mucus, you know, blood gases, that whole thing, clubbing of fingers, anything, you know, with perfusion, that would be a sign. Appetite, weight gain. Do they have activity tolerance? Do they get short of breath with different play activities? So increased need for pulmonary and pancreatic medications. It's pancreatic enzyme that they need to be taking. Presence of fever, presence of bone pain related to growth and nutrition, any other changes in their physical state, and what is their medication regime? So that whole head to toe, right? So I won't read all of this for you. So we're just, from head to toe, general appearance, respiratory, looking at abdomen, looking at, musculoskeletal changes, barrel, chest, club, fingers, work of breathing and oxygenation, and GI and nutrition and skin and perfusion, overall inspection. And then more specific, so from inspection to auscultation, percussion, do they have dense areas over the lung that are dull as we're percussing, as we're palpating? Is there any air, tactile fremitus? Is it conducting well? When they say 99, do we feel that vibration? Tenderness over the liver, right? Is there indication of cor pulmonale or ascites or, liver involvement? Esophageal varices, that kind of. So the labs and diagnostics are basically your sweat chloride test, pulse ox, chest x-ray, pulmonary function test with RT, looking at, volume, lung volume, respiratory effort, expiratory volume effort, forced FEVs, forced expiratory volumes, to look at inflammation in the lungs. And this is your patient that is going to have aggressive pulmonary toilet, okay? When they're at home, they're going to be getting nebulizers, vest therapy that vibrates and helps break up and mobilize secretions in this thick mucus, right? Hydration is key. Making sure that their nutrition, in terms of preventing infection, they have to have optimal nutrition. In terms of having energy, you can imagine with activity tolerance, with the work of breathing and everything, they're going to have more calorie requirements. So maintaining that growth, preventing infection, promoting family coping, right? Because this is a chronic disease and it's not curable, right? And it's progressive. So the more that we can coordinate their care services with their primary care doctor, with, immunizations and preventing infection. So primary care, nutrition, maybe PT, OT, right? Respiratory care, and then their pulmonary physician. And, this would be, in a perfect world, this would be your patient that should have early palliative care. And I'm not talking hospice, but I'm talking that, they have this chronic condition and we're going to be anticipating them going in and out of the acute care setting multiple times in their life, and looking at how you can promote family coping by having a palliative care team that helps them manage this chronic disease. But that's not our reality yet. We tried to get there, and we just couldn't get reimbursement from insurance companies. It's not an approved service right now, and unless there are, that I know of any, health insurance. But in a perfect world, that would be how we would, manage and support families with this diagnosis and others. But as much as we can as nurses, right, when we look at health promotion and maintenance and everything, providing that anticipatory guidance, with, flu season is coming up, obviously these are people that cannot get COVID, right? Like right now, right? I would hope that they're looking at strict, isolation, right? So then how do you then help them cope with that situation also, right? So, so where are we at for time? 10:39. Okay. So, any questions about cystic fibrosis? So I have an assignment in here for you in Blackboard. You can pull that up. This exit pass assignment. So here's your exam 2 study guide. Okay, so you guys can get going on that. And I did post the chapter PowerPoints also, because sometimes those are nice to, you know, like how I wanted you to kind of peruse through the different exemplars. So you have PowerPoints for those chapters. Won't need to know it for the test, but we'll need it for like the pediatric Kaplan later. Exit pass questions. There's 4 of them in here. Relating to immunizations. And then our, what's this one? Ear infection, right? A right ear infection.
We can't see your screen.
Oh, you can't see my screen. Thanks for letting me know. I can see my screen just fine. Here, let me try it again. Sometimes I don't know why it doesn't populate back over when I, you know, like if I go from one thing and sometimes it does, and sometimes I think it glitches and it doesn't. Now you can see it, right?
Yeah, we can see it now.
Mm-hmm. Okay. So a few questions related to immunizations. You got JKA, 12-month-old, right? So purpose of immunizations, what could they expect to receive at a visit if he's 12 months of age? Differences between active and passive immunity, barriers to receive immunizations, okay? So just some, doesn't need to be extensive. You can have brief answers to these. Do use this also as a study guide to prepare for some exam questions, okay? And what I want is this submitted to the journal for this week as an exit pass from class. So you're going to review these questions so this is making up for this next time from now to noon. I'm using this as an opportunity to try some different things instead of the 3-hour lecture of Zoom class. Okay, because rather than I could have put these on slides and we could have discussed them as case studies and done that in class. But I know that sometimes it's better for students kind of work on their own time so that we don't have students, you know, saying answers when other students are trying to think it through more. So you can do this on your own and submit it to the journal. And the journal is titled Exit Pass for this week. So then we have Joshua and a couple questions on ear infection. We have a couple questions on epilepsy and a couple questions on cystic fibrosis. Okay. So that's what you have for next week, along with your study guide. And your exam is on the neonate at risk, neonatal assessment, and exemplars, and then your pediatric atraumatic care, family-centered care, exemplars, assessment, a pediatric patient. So follow your study guide. And you're on your own, okay? Exam next week. And then we're gonna move on. We're gonna kind of go back to alterations in sexuality. We're gonna look at STDs, kind of have a fun project for that. I'm looking at what I wanna do for week 8 too, because we have the Kaplan coming up on OB and the newborn. And that's also gonna be game day week. So I wanna see if there's some way you can I could get you in teams and you could do games and bring them into lab. And I'm thinking if I could either set them up in different classrooms or out in the patio in the courtyard area, if I could get approval for that, we could have your game set up. And after you do the Kaplan, you could go out there and do the games to learn about the different exemplars. So I'm looking at how I can, you know, alter that and of course we never know, you know, what campus rules are going to be, but I have time to finalize how we'll implement that. Okay. Any questions about where we're at and where we're going? I'll assign prep views also on the chapters. I'll make sure those are all in there. But you know, you can always go in there on the assigned readings and do them on your own too. Okay, they're not a ticket in, they're not graded, but I'll have them in there. Anything else you need from me?
So just to verify, there's no assignment due like next week, just the
Exit pass, the questions. I want you working on your study guide. I want you doing your prep views. I want you reviewing all your stuff that we've learned so far for the exam.
Thank you.
You're welcome.
Miss Erickson, are we submitting our exam guides?
No, you can always send them to me. I'll look them over if you get them done early.
Okay.
I trust you're at that point. Your third semester. You know enough to do them, right? You know how I work. Okay. Okay, well, you're getting off early today. I remember this, okay, because I know I've had some intense 3-hour lectures. So, see, Lily?
Yes, I see. You're doing great.
I do listen occasionally, right? But you'll still learn. You know, like I said, we could have done it in class, but this way you're doing it on your own. But do it, okay? Do the questions on the exemplars, because I'll take stuff off of there for the exam, okay? Okay.
Thank you.
You're welcome. Have a great afternoon. Now see you'll be all fresh and ready to go for Ms. Edwards, right?
We don't have any more Zooms today.
You don't? What is she doing this afternoon?
We're doing an in-class assignment. Like
It figures, right? Well, but we still had lecture. We still had some. Okay. You had enough, right? I could keep going. You know that. Okay, take care. I'll see you guys in clinical tomorrow, bright and early.